Доброго вечора, українські радіаційні онкологи, медичні фізики та радіаційні терапевтичні технології. Слава Україні! Дуже дякуємо, що доєдналися до курсу Modern Brachytherapy Course with ABS Experts for Ukraine. My name is Serhiy Brovchuk. I'm a medical physicist at Lisot Israeli Oncology Hospital, and also I'm a physicist at Alexander Shalimov National Scientific Center for Surgery and Transplantation. I will be co-moderating this lecture today with Arjit Bakhwala.
Good evening, everyone. My name is Arjit Bakhwala, and I'm a physicist at Houston Methodist Hospital. The topic for today's lecture is brachytherapy physics and technology, and our speaker is Dr. Peter Sandwall. Dr. Peter Sandwall is a board-certified medical physicist, clinical therapeutic physicist at Ohio Health Mansfield Hospital, and holds an adjunct faculty position at North Central State College. He is also the president of Precision Physics Incorporated, a consulting firm he founded in 2012 that offers radiological physics services across the United States and Latin America. Dr. Sandwall earned his PhD in nuclear engineering from the University of Cincinnati in 2014. His research encompasses radiation dosimetry, medical radiation physics, stereotactic radiosurgery, and brachytherapy, with numerous publications in these areas. An active member of the medical physics community, Dr. Sandwall has held leadership roles such as past president of the Pennsylvania, Ohio, West Virginia chapter of the American Association of Physicists in Medicine. He is also a board member of Radiating Hope and has contributed to organizations including the Boy Scouts of America, Health Physics Society, Rayos Contra Center, and Rotary International. It's an honor for the Ukrainian radiation oncology community to have Dr. Sandwall as a speaker in this course. Thank you so much for teaching us today on brachytherapy physics and technology. The podium is yours.
Thank you, Arjun. I know you had a script to read. You are the real brachytherapy expert, and I'm glad to. I'm really honored to have your introduction, and it's a pleasure to be here and a pleasure to share with you all. We've been working alongside doing many of these programs, and I'm sure that there are some familiar faces on the call beyond Natalia and Sari, which I am very pleased to see as well. So I'll jump right into it. This is the title of the slide is physics and technology. The order is actually technology and then physics. So
do you mind sharing?
Do you not see? Oh, no. I thought I did share. Select a window. Oh, okay. Okay.
Yeah, we see it. Great.
Perfect. So this is the title, Brachytherapy, Physics, and Technology. But we're going to talk about the technology before we talk about the physics. And the technology will be kind of all-encompassing, since I know that many centers may not have brachytherapy, but may be exploring the development of brachytherapy and or adding that service line. We'll kind of look at it from a holistic approach. So this is kind of these are the learning objectives for kind of the first part. This is the technology. So understanding HDR as a modality in terms of the treatment process, the patient selection process, clinical outcomes, what can you expect? And then again, this is going towards the development process. If you are looking to build a center or looking to add this service line, what do you need in terms of staffing, the room, the treatment equipment, and the imaging requirements? There are different ways to accomplish the same goal. So we'll talk about some of those options. And then it's really important not to neglect the finances. For many years, I'm a healthcare professional, and I'm doing this to help people, but I understand that healthcare is business, and you need to have finances to make it sustainable. So this is an important consideration. How much is it going to cost? How many people is it going to serve? are you going to get a reasonable return on investment? So then we'll close out with a basic review of the physics. I know this is a large course, and you're going to have some overlap. So concepts that I introduce will likely be gone into greater detail later on in the course. But what I'll focus on is the different types of sources in that respect: the iridium and the cobalt. And I know that there are some investigative sources, but those aren't the focus of this presentation. But I do look forward to seeing data as that comes about. So just something to look for. So let's get into it. I know that last week you had a review of the history, but like I said, there's a lot of overlap between these things. And I love brachytherapy, and I love kind of its history because it's intertwined with the history of science. And so we have these key individuals here. I think many of you are probably familiar with them. Henry Becquerel, and his discovery of radioactivity was just based on wonder. He was wondering, he was fascinated by the phosphorescence of uranium glass and what caused this. And that led to the discovery that there's actually radioactivity and there's spontaneous emissions. And then working with collaborators or lending some elements to Marie and Pierre Curie, who dug deeper and discovered and isolated radium. And radium was an incredibly powerful isotope. And that really led the way towards the therapeutic use. The story is that Becquerel actually had a piece of radium in his pocket and got a skin ulcer, he got a burn. And that was what led to the thought, well, maybe this could be used therapeutically. And then they lent a sample source to a physician. So that source, and I don't have too many history slides because I don't want too much overlap with last week, but I do have some. But that physician was Henry Danlos, and he treated a superficial lesion in 1901. And there is it's somewhat contested, like who was first. It doesn't really matter who was first. The fact was that it was recognized as a technology, or there was an opportunity to help people and to treat cancer. So Henry Danlos was one of the first, and he put the radium directly on a superficial lesion. This later on led to the development of standardized sources, and you can see here these are capsules in which radium was loaded, and then later on needles. And these methods, they actually kind of paved the way with our units. So for many years we used radium as the standard. Only later did we move our units towards Systems International, and we'll talk about that a little bit later. This is again a review, but the important thing here is how it has developed. So we know brachytherapy, brachy means short, so we're delivering the radiation with the source close to the target. It's in close proximity to the target. So for many years we had radium, and then in the 50s, post World War II, when we had reactor-produced isotopes, we got cobalt-60 and we got cesium-137, and we used cesium-137 for years as a low dose rate source. In the 60s, we were able to activate iridium wires, and we would use those for interstitial implants. Only later was that miniaturized into the current seed-based source that we have today. And that, coupled with remote afterloading, is what gives us the HDR, the high dose rate brachytherapy we know today. So that's just a brief review of the history, which I think you got last week. But there's always that overlap. So here's the let's get into kind of the technology or the overview of the actual procedure, its implementation. How do you implement it? So the treatment process is pretty straightforward. It's complementary to external beam planning. There's treatment planning. There's placement of the sources. Then there is optimization of the treatment plan. So in this respect, treatment planning is when the physician creates their intent. They decide, okay, I want to treat this. Then there's a placement of the source, and then there's the three-dimensional treatment planning that we know from external beam radiotherapy, where we have the source, we have an image, and then we go ahead and we do the treatment delivery. So it's a process flow, and what you don't see in here is the imaging, because historically we didn't do the imaging. It's only recently that we have incorporated more imaging into our treatments. And we'll talk about that a little bit further. So this is for the physician, for the clinicians, who is suitable for brachytherapy. I think many of you know about its use in cervical cancer, and we'll touch on that. But there are other ones, and a good brachytherapist, a physician who really enjoys the practice of brachytherapy, can find innovative ways to use brachytherapy to get really good cure rates. You can get dose rates much higher than SBRT with brachytherapy, but it takes some courage. It takes hands. There's some manual dexterity to delivering brachytherapy. So patients who are good candidates, they're a localized cancer, obviously can't be diffuse. You're not going to be treating a large volume. Relatively a small tumor volume. You don't want it to be too large. That's not to say that you can't treat large volume, but in that case, it's kind of more, in some respects, it can be palliative and or adjuvant, used in conjunction with external beam. And if you do have a large bulky mass, that gets into using interstitial needles, and again, that's very skill-based. You want to have a patient that has good performance status, so that they can tolerate anesthesia. If you're gonna put someone to sleep, you got to make sure that they're well enough to wake up. You don't want to assume that risk. So the performance, a good performance status is important. And then you want someone that's compliant. If you're going to have them in bed for 2 to 4 to 6 hours, you're going to want a patient that can do that. And we've all worked with patients who have a hard time sitting on the table for their external beam treatment. Those aren't good candidates for HDR, because they're going to be in the treatment position for much longer. And what I mentioned before, adjuvant or concurrent external beam radiotherapy is very common. Obviously, the cervical cancer is a prime example. We typically do an external beam and then followed with the brachy boost. So as far as clinical outcomes, this is a little Clint Eastwood, the good, the bad, and the ugly. It's an old Western. But there is a good, a bad, and an ugly to brachytherapy. So the good outcomes, we get really a high dose of radiation to the target, and we can minimize that adjacent dose. So we can get good disease-free survival and significant improvements in that regard. Again, the dose escalation you can get for brachytherapy is unmatched. The bad, so you can get acute side effects. When you're dealing with these high doses, that can lead to other issues. So you can get localized bruising, swelling, bleeding, especially if you're doing things interstitially. So there is kind of a good brachytherapist is someone who likes to actually work with their hands. But that being said, we're not looking for orthopods. We're not looking for bone people that are rough. To put in an applicator takes a delicate touch. There are other elements in terms of depending upon where you're treating. If you're doing something near the GI, those are obvious side effects that you can have in terms of incontinence. And in some patients, again, it's very skill based where you place that source. You can have some long-term side effects. Again, this can be incontinence and other GI issues. So the ugly, and it's a lot of people, we like to just talk things up. It's very important to look at things like holistically and look at what are the drawbacks. So if you have a patient, what are the risks to this patient? Is this a good procedure for this particular patient? I've been saying this all along, but I really mean it, and I'm trying to hit it here. It's really highly dependent on operator skill and experience. It's an art form. A lot of external beam radiotherapy, we have good guidance, and there is an art form in discussing with the patient their treatment options and balancing the risks. In this case, it's more than just balancing the risks. It's also how good or how well you place that source near its target. This is a really, it can't be understated. If you're not comfortable, if you're not confident, you should get more observation hours, and you should get more time under a skilled practitioner. So be careful. It's something to be respected. All right. Now we've got our first question. So to make sure everyone's still awake, I know we just started, but let's get to our first question. So what is the physical advantage of brachytherapy compared to external beam radiotherapy? Oh, let me move this over here. So feel free. I see the poll up. I don't know if the rest of you see the poll up.
Yeah, people see the poll, so we typically wait until 80% answers because that's how we take attendance.
Okay.
And I'll make you also a co-host so you could see the answers. But please do not interact with it. You'll just close it.
So we have about 75% of answers. 80.
Nice.
I think I can end the poll.
Okay. Well, we have excellent results. The vast majority of you, the overwhelming majority, got this correctly. It is B. It delivers the dose very close to the tumor, with a steep fall off in surrounding tissues. So that's the beauty of it. It's the danger is, again, it is making sure you have it placed in the correct position. So now let's get into kind of more of the flow. So we're just going to increase in complexity as we go. So let's talk about what you need to perform brachytherapy or to add this as a service line. So there's some great guidance documents. I love the IEAE documents. Just one, they're free, they're easy to access. They also typically have good references. So if there's something that they don't go into a lot of detail, there are often good references in there that do. So you can go down the rabbit hole with the references. But they have this one document, setting up a radiotherapy program. That's an entire comprehensive document, and it's not just setting up brachytherapy. It's also setting up external beam, and the brachytherapy element is a piece of that. Another one is the implementation of HDR brachytherapy in limited resource settings, and this is appropriate for all. This document is appropriate for those in high resource settings it's not, I don't want it to be, oh, this is just for those without. This is for all. The thing that they emphasize in limited resource settings is doing the things that have the highest yield. In the States, for example, we may have like a strong guidance that says you've got to do the whole alphabet of tasks. In the IEAE's guidance is a little different than ours in the States, and it's do those things with the highest yield. Do the most you can with what you have. That being said, I've mentioned it before, with brachytherapy, your skill, your user, the physician, the clinician's skill in delivering it is of the utmost importance. So don't shortcut human experience. That's massive. And that's the first thing on the list is staffing. So our human resources are our most important one. Then we can get into the requirements for a room, and those vary. You can make do with less equipment or more equipment. There are different ways to peel an orange, and then that leads to the treatment equipment. We'll talk about some of the different afterloaders. Not all of them. My list isn't expansive or exhaustive, but it's decent. It hits the major players. And then imaging requirements. And the imaging requirements vary significantly. You can do planar radiography, and this is what we did for years and years, and that's what much of our clinical data is based off of, is planar radiography. The last couple decades, we've transitioned to 3D, and we've moved even beyond CT to MR. And anywhere on that spectrum, you can still deliver quality care. And so that's what I'm saying in terms of your resources. If you don't have the resources for an MR-based program, that doesn't mean that you can't deliver to high quality care. You can also do it with templates, and we'll talk about that briefly. And then again, finances. I think it's important to consider, especially if you're going to make a case to hospital administrators that you want their support to build a new program. And if you're building a program from the ground up, there's a lot of advantages to creating the space. If you create the space, you can create a space that allows for efficient delivery. And I always say an efficient process is a safe process. So let's talk about staffing. So it's much more labor intensive than external beam radiotherapy. So external beam, you may have 2 technologists on the unit, and they're treating 30 patients that day. Brachytherapy is a team approach, and there are different ways to assemble a team. Here I'm showing one way to assemble a team. I've seen where these roles have been collapsed and still delivering quality care. That's the big thing I like to stress. I know that there are different ways to do things, and you can still deliver quality care. You just have to be very clear about the role assignments. Who is performing what task? Who's second checking each other? It's really important to have a flow chart of your tasks. And if we can get into a little safety, I'm sure you'll get a lecture or you'll have a presentation on this later on. But looking at this from the beginning, being prospective about your risk analysis is really important. So it requires direct input from all the disciplines. This is, again, I'm saying some of these things can be collapsed. I'm not sure. I guess I should know at this point. I've been interacting with Ukrainian physicists, but I don't know if you have a specific dosimetrist role and or if that's consistent. So no, you don't, and that's not uncommon internationally. So these roles that we have under a dosimetrist, they could be, if you have an adequate staff, they could be performed by a second physicist, and then you get second check. But I've also seen it where it's just a physicist and a radiation oncologist. where the physicist acts as the operator. And so it's this particular outline from TG59 is not prescriptive. This is not for you to do as it's set out. What it's doing is it's showing you how you should map out your process, because your process may be a little different. What's more important than following anyone else's recipe is making sure that yours is very clear and that the roles are well defined. So good communication is really important, whether you have a team of 5 or a team of 2. That communication is essential. This is again, these are idealized FTEs, and they may be good for your business model that you present to the administration to add this plan. And then maybe you have some wiggle room in terms of what you actually implement. So the room requirements. There are some things that you need, that you must have. You need to have a place to insert the applicator. Dependent upon the procedures you're doing, if you're doing intercavitary or if you're doing interstitial, those have different sterility requirements. So you have to be very mindful of that in terms of what procedures are you going to be performing, and then those will have some an impact on the room requirements. So you also have to have a place to deliver the treatment. So this is a place where the afterloader is stored. The imaging system, you need to be clear about what imaging you're going to be performing. And a planning room. Sometimes these places are all in the same, are all very close at hand. Sometimes they're in different areas of the department. But this is something I want to stress. The closer you can have these things, or the smoother you can have your transition from these different places, the better treatment you're going to have. The more you move that patient, the more uncertainty you enter into the treatment process. So you really want to focus on flow and aiming for a smooth and flow. So movement of the patient, you want to minimize that. And it's really important once you've performed your imaging. So these are some options. I'm giving some options for how you might have the layout. So one, you could have the treatment room with shared use. So you could be using an existing OR theater or procedure room. Doesn't necessarily belong to the brachytherapy program. It's scheduled and used by the brachytherapy program when they have a treatment. And it could also be a shared room with a simulator. You could have your brachytherapy in a locked cabinet where your CT scanner is. You can also have a room where you put the applicator, you insert the applicator, and you deliver the treatment, but you move the patient for the imaging. That's performed elsewhere. That's a very common layout. However, be very careful with that patient transfer. And this device I'm showing here, this Zephyr, I think they were the first to, or at least the first that I was aware of. They kind of made like an air hockey table. So it created a smooth transfer. There was no lifting of the patient. You didn't have to pick them up on the sheet and move them over, or pick them up on the plastic gurney. You were able to kind of just slide them over. And that was a really nice innovation. I think that there are others who offer similar devices now. But the important thing is, if you do have to move the patient, you really want to do it carefully so that the applicator is not displaced. So the dream of all brachytherapists is to have one room that does it all. I know that there are some that are lucky, and if you are building a program, this is something that you can strongly advocate for. And that's an integrated brachytherapy suite where you have your afterloader, your imaging, and you do your insertion all at the same place. And this is kind of the ideal setup. So you can envision that you have the patient sit down, you insert the applicator, you scan them without any, obviously the table's translating through the bore, but they're not moving and displacing the applicator. And then you hook up the afterloader and perform the treatment. That's the ideal. So we have our next question. So this one I hope I'm aiming for 100% or at least 97%. So
Okay.
why must imaging, planning, and treatment often occur on the same day in brachytherapy?
While people answering the question, what is set up in your clinic? Do you have a CT in the same room as brachytherapy unit?
So we have brachytherapy in 2 of our hospitals. In one we do, in one we don't. So in one we have in our newest hospital, our newest center that they put brachytherapy into, we have an integrated suite where the afterloader and the CT scanner are in the same location. Our previous one, oh, go ahead.
Regular CT or the one like a Mobius or some lower?
It's just a wide bore CT. So,
Okay.
and our old one, they have to go down the hall, so they get gurneyed down and back. So they get the applicator inserted, then they go to CT, they get scanned, and then they come back, and then they get the treatment. Obviously, we prefer the integrated suite.
Yes.
And it looks like we have 87%.
Yes.
And oh, looks it's going a little bit more, 89%. So we got decent results. We got decent results. And the other one, the minimizing source decay, I understand where that's coming from, and that's actually that's valid. Not what I was looking for, but it is true. We do have the source decay that we planned for based on the day that we do the treatment plan. So if we did it a different day, there would the source would have decayed. But we want to maintain the geometry and accuracy of dose delivery. This is essential, and this isn't just about the same day. This is about really ideally if we could have them in the same position consistently. That's ideal. All right. So now let's get into some more of the equipment. Maybe the equipment that when people think about technology, this HDR technology, brachytherapy technology, I think this is what they think about. So remote afterloaders. Now, I've mentioned this in previous discussions. My worldview is limited. I'm aware of that. So there's a lot of things I don't know about. Coming from the States, I know about Electa, I know about Varian, and I haven't personally worked with Eckert and Ziegler, but I know them through others. But I am confident that there are other brands out there, and I would like it if anyone anyone is working with another brand, please type that in. And I'm also aware that there are I think legacy systems, and I'm curious what some of those are. So please, if you have an afterloader, or if you've worked with an afterloader from another manufacturer, please share in the chat and help broaden my perspective. So we'll talk about the remote afterloaders that I'm aware of, and I know that there are others. So are the ones that I kind of have an understanding of. And we'll talk about briefly talk about applicators, not in too much depth because there's libraries of applicators. There are many applicators as there are books in my office. Maybe not that many, but There are a few. And then we'll talk about just briefly some of the equipment that you need to do for applicator commissioning. You're going to need film to ensure that the source is going to the correct place. And I think you'll talk about commissioning applicators in a later discussion. Then a well ionization chamber to ensure that the source strength is as expected. And I include this just because I know these things are done, and they can be done efficiently. They can be done safely. So people have used farmer chambers to check the source strength of HDR units. That's not the preferred method, but there are ways to do things when you don't have some of the things that you would like to have. And then obviously there are planning systems, and that's a big part of delivery. So this is a table that kind of compares and contrasts some of the major afterloaders. The one, I think the omission on my part that I would have liked to add is the Saginova. I believe that the Saginova is similar to the multi-source, but I believe it's slightly different. But what you see here are a couple of, there are two that provide cobalt-60, this Flexitron and then this Bevig. You have a lot of other ones that are capable of providing iridium from, and thinking about 10 curie of iridium, that's a very common source. The Flexitron has heavier shielding. I know that they've thought about other sources and even multi-source. They've thought about that idea in terms of you're not just using one source to create the dose distribution. Maybe you can use two. And then what you can see is that the size of the source is roughly the same. They're all about the size of a grain of rice. The max cycles, this is the amount of outs and ins. The cycle of sending the source out and bring the source back. And this is based on the motors. These are a little different, and so you see the VeriSource is only 1,000, and that's not saying that it can only do 1,000, but it's typical. What they're wanting is to do a source exchange and do a PMI at that point. But this Bevig is designed to be robust. Some other items, the needle, the diameter of an interstitial needle. So some of these are a little narrower than others, and then the way that they're attached to the source cable, mostly laser weld. So the seed is welded to the end of the wire, and there is the tragic accident where that weld broke, and there was a chemical reaction that led to a weakening of that weld, and then the source came off. And these things, I bring that up just because some of these things are called like never events, but never events do occur. There is no such thing as never. Sources do get stuck, and sources do get stuck in applicators, and it's really important to understand your emergency procedures. Just because you think something's not going to happen and then it does. I've known at this point in my career, I'm aware of too many sources getting stuck outside the vault of the afterloader to say that doesn't occur very often. It occurs. Hopefully you don't experience that, but it does happen. Then the extension is slightly different for some of these. This comes into play with your transfer guide tubes. That's also a common source of error. If you have a transfer guide tube that's 130 versus 150, that can, or if you have one at 150 rather than 130, that can lead to an error. So knowing your extension and knowing your transfer guide tube and having awareness of that is important. Then you have some different, they have some different speeds, and they have different number of channels. This is essentially the number of applicators or interstitial needles that you can connect to. Now I have the last line, I highlighted that step motion because this is another common source of error. This is a common failure point. So you get people that train on Electa with step in. So this means that the treatment goes from the distal to the proximal end. So it goes do, 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 do. When they may train with Electa, but then they maybe switch to Varian or vice versa. And vice versa does the opposite. It goes proximal and then it pulls out. So whether it's step in or step out, just know your HDR, know your afterloader. It's very important not to take it for granted. Oh, I've worked with HDR, you know, they're all the same. I'll just hop on this one and create a plan. Be very mindful when you switch vendors or you switch equipment. Understand that they're not all exactly the same. And this if you plan backwards, if you plan for one and expecting the other, your dose distribution will be flipped, and that can lead to complete geographic misses of the tumor, and then you're delivering a really high dose to normal tissue. So this is something to be very mindful of. So this is the kind of the guts of an afterloader. They're really beautiful in terms of their simplicity. I think maybe the word would be elegant. So you've got a nice stepper motor. You have two. You have one for the check stepper, and then the one for the actual live source. And these designs vary, and this is a particular design. Yet they're all very similar. Some of them just have slightly different implementations. They all share a safe. And then what they also have are they have encoders to indicate which index or what channel they're going to. Some of them also have, not only do they have stepper motors with encoders on them that tell them how far it's going, but some of them also have optical encoders that are telling them how far out the wire is. That doesn't mean that these systems don't fail and shouldn't be checked on a regular basis. But these different optical encoders are responsible for kind of determining where in space the source is. And briefly, like I mentioned, there are a whole host of applicators. There are applicators for just about anything you can imagine. This one over here, this one with the blue needles in between it, that's for breast. It's not as common anymore, but that was a popular procedure for a while. You have a lot of other ones for GYN cases. You have these ones over in the upper right hand corner. Those steel caps. Those are for superficial. And HDR is great for superficial treatments. It really has good results. You have them for prostate. You have them for even for esophageal. So there's a lot of different options in terms of applicators. What you have to be mindful of is what imaging are you going to be using for planning? And that informs your applicator choices. So if you're starting a program or if you're building a program and you've looked at what kind of cases you want to treat and you're going to get those applicators, it's really also important what kind of imaging you're going to perform, because if you're going to do MR, or maybe you plan to do MR later, You're going to want to make sure that you have MR compatible devices. And the same thing with CT, you can get ones that don't scatter as much. And here you can see a bunch of artifacts. And then we also have an MR and CT registration here. So be mindful when you're selecting your applicators, what imaging you intend to use. So let's talk about the options. So historically, we did this with planar radiography. We used old simulators or traditional simulators, I should say, not old. If there aren't, they don't have to be. I think these are still manufactured C arms, and you can use a fluoro unit. But these simulators, these traditional simulators, were C arms like the accelerator for external beam radiotherapy. But the beautiful thing about these is you can rotate them and get them at the right angle to really visualize the applicators in the body. And here are some orthogonal radiographs, and you can faintly see some lines that were used for the previous type of treatment planning, where we would calculate the point A. We would use point doses and just distances. Now, more often than not, we've migrated to using CT sims. And I have here an intraoperative cone beam. You can do this. You can be creative. It depends, and I'll touch on that. It kind of just depends on the calculation model you're going to use. TG43, it's already treating everything in water, so the Hounsfield units are less important. It's more about the spatial location. But CT simulators allow you to plan in 3D. They allow you to see where the applicator is in 3 dimensions, and then create a 3-dimensional dose distribution. And now what's becoming more popular and has truly become the gold standard is MR. And not everyone can afford, and I don't say afford just in terms of buying an MR, but the logistics of planning an MR, especially if it belongs in the Department of Radiology, it can be prohibitive. Getting that time and getting a smooth operation where you're actually moving between the applicator placement and to the table for the imaging, and then back to the treatment room, that can be hard. That being said, I've done it. It can be done. It just takes a lot of communication with radiology, and so it's a lot of time that MR doesn't belong to us. So we just have to be respectful of their time and collaborative. But MR can really visualize soft tissue. It's really good at it. You can also make high risk CTVs and low risk CTVs. This is kind of the gold standard. This is where we would like to be, but we understand that MR is not cheap, and people need those. What's another thing that we use ultrasound traditionally in with prostate. We've done ultrasound for LDR prostate for years. Ultrasound is not used so frequently for HDR, but that's not to say that it can't be. If you are going to go down that road, make sure whatever you do is evidence-based, and hopefully you share your experience. But I know that this is an active area of research to kind of lower the costs and to make it a little bit easier, so you don't have to move them between tables. But ultrasound you can't necessarily do the 3D planning, but you can verify the location of the applicator if you're going to use a template plan. So I mentioned before that there are other elements beyond just picking out the things that you want to buy, you have to be able to make a case to administration why, and then what you're going to need ongoing. This is one of the things I've seen in my own experience, is that people will make a case and they will get approval and they will start a program. However, they haven't projected what their needs are going to be in 6 months or 6 years. So that program doesn't continue to flourish because there isn't reinvestment into it. So it's really important that when you're making that case, you're upfront about the ongoing costs. So it's not just the equipment, the capital that you need in equipment, but it's the investment in human resources. So I've already mentioned how user dependent, operator dependent brachytherapy is. To be good, you're gonna need to be constantly learning and relearning, and hopefully you're getting you're going to the conferences and you're exchanging experiences. And so this is something that the human resource investment is important. So you have the capital investments that you need, that you start with. So that's the construction, that's the equipment, but then you have the ongoing, the service, and then the staff, that invest in the staff. This is a really old equipment costs, and these numbers aren't valid, but what is valid is kind of the list of things to look at. So these dollars that's not what they are anymore, and they would likely be different for Ukraine. But what this can give you is an idea of things that you're going to need to outline in your proposal. So what's the brachytherapy unit going to cost? What's the source exchange? This is 4 times a year for iridium. It's going to be different if you have cobalt. What does that cost? This is also something that I've seen. I don't believe it'll be such a problem in Ukraine, but there are, if you're getting a source and it's coming from Germany, or if it's coming from Canada, you need to make sure that those pathways are clear, and you can have that source come into the country. I've seen that fail sometimes. What are the other equipment you're going to need in terms of applicators, catheters? Which ones of these are disposable? What are consumables, and what are things that you're going to have? What are the lifetime of those applicators? So when are you going to need to plan for replacement and/or budget for replacement? What QA equipment do you have, or do you need? You need a well chamber. Do you need a decent supply of film? What are the things that you're going to need in terms of survey meter, the treatment planning software? Again, all these things you want to plan ahead for. And actually, number 10, it's more than ever. It's an issue. So even though this is kind of, they don't even have a value on that one, IT is important. Data security is important. So having all this outlined, giving your administration an idea of what they're getting into is important. So some other factors to consider. So radiation safety, you really need to have annual training, and people need to take it seriously. Like I said, those never events, they're not never events, they do occur. The worst thing is to have an event and not be ready for it. So take it seriously. HDR is not, it is a very high dose, and it's not so much of a risk to us as the operators. It's really a risk to the patient. If you have a source left in a patient or stuck in a patient, it's imperative you get them out. And it's only by training for that failure that you can prevent it from being really harmful. So human resources, again, I've mentioned that. So training your people and ongoing and continuously learning, that's so important. Again, when you're assembling your budgets or your justifications for your program, it's really good to know who you're going to treat. This also informs the applicators that you purchase. So you can look and see what your census was or has been historically, and maybe you know that you're going to mostly be treating cervix, or that you're going to be treating prostate or breast or esophagus. These are all big ones, but you should have an idea about how many patients you're going to treat. Does that amount of are you going to treat enough to maintain competency? If you're only treating 2 patients a year, you're not going to be maintaining competency. I always say a kind of a minimum of 5 cases. I understand that some people, well, everyone counts, but if you do it wrong, it's worse than not doing it at all. So this is things to consider when you're justifying your program. So these are the kind of the key points from that element or those elements. You want to have that awareness of your patient population, the staffing model you're going to use, and how many you're going to need, what facilities you have available, what's needed to start and maintain a program, what are the costs of the imaging technology, and what are the benefits. So what are you going to be treating? What imaging is going to be ideal for or optimal for your patient population? And again, this goes to the layout of your program, your department. Location matters. If you're building it from the ground up, that's great. You can actually design your building, or you can design the flow. It's very important. The flow is very important. So I've got another question for you, and we're more than halfway through. Because we're on time. So let's see. Question number 2: which factor most strongly determines the efficiency and safety of a new HDR brachytherapy program?
And I think this is a number 3 question, right?
Yes, it is number 3, not number 2.
Yeah.
Yeah, but it's the same. This one. Okay.
Yeah, it's correct question. Mhm. There's also a question in the chat. Could MRI CT scan be used to calculate 3D dose distribution using sort of calibration curve?
Well, again, it depends on what you're doing. I don't go deep into the different calculation models, but we do have TG43 treats everything as water, so it doesn't necessarily matter your imaging modality that much. There are newer calculation models like Acuros that are solving and taking heterogeneity into account. If you're taking heterogeneity into account, you are going to want a good electron density calibration curve. That being said, many people make synthetic CTs from MR. So there are ways to use MR for treatment planning. So I've got 83 participants, and I do want to kind of make up for some time. So I'm going to go ahead and end the result, or end it. And the majority of you got this right. This is what I was looking for, was this proximity of imaging, planning, and treatment rooms. However, you're not wrong. Those that answered choice of isotope, this is a very valid response. It does. I don't know that it's so much so much impacts the efficiency, but it is an important thing, and especially it does impact safety in terms of the shielding concerns. But the answer I was looking for was the proximity. I want it all to be close together. You want that integrated suite if you can. If you're starting from the ground up, that is kind of the ideal. So let's keep going. So now we're going to do the physics. So it was HDR brachytherapy, physics and technology, but really we kind of we went over the technology. Now we're going over the physics, and we'll start from very fundamental element. We're going to start from kind of the units, and then we'll go on to kind of the interactions and actually how we. One of the big thing is how we quantify our sources. We're using radioactive sources, and we'll talk about that in terms of activity versus air kerma and air kerma strength. So, and this is kind of just a picture I found just for this. I like images. It's not it's kind of a blurry image, but it's an image nonetheless, and it really shows you the basic principle of using a stepping source. So the longer you have it somewhere, the dose just deposits just based on time. So if you're for a brief period of time, it's a small amount of dose. There for a longer period of time, and the intensity just grows proportional to dwell time. So the basics, radioactivity, which I think is reviewed to probably all of you, and it's funny because I remember like in graduate school, I felt like my first semester, it was just, they were all the same class because they all said the same thing. And so this is just one of those things that just we say again and again. But the radioactivity, it's just the release of radiant energy. In this case, we've got alpha, beta, gamma, neutron, and for most of our brachytherapy sources, we're relying on the gamma. And then there are some newer sources where they're looking at beta, but that's kind of more forward thinking. But one of the reasons for this is the unit of activity. So it's the becquerel. It used to be the curie, but then it became the becquerel. This is the system international. So the curie was based off of a unit of radium, and then the becquerel is more of a fundamental 1 disintegration per second. One of the reasons that I show this is because sources are sometimes or often spoken about in terms of activity, and I'll move on to other units. But it's important that we're mindful of the units that are being used or that are maybe on our source certificate. You would like them to be uniform, but they're not. I mean, we all know that centigrade isn't really it's not an SI unit, but we use it nonetheless. So decay, again, review. We know that the radioactive elements have a half-life, and that half-life is actually is related to their specific activity in terms of like how quickly they decay, how much energy they give off. And this is just a decay chain. Again, nothing earth-shaking here. Your standard radioactive decay equation at the bottom. And I actually have this here, this first order differential equation. It sounds complicated, but we all know it's not that bad. I remember it from a lecture given one time, and it was essentially that we expect all of our graduate students to be able to solve a first order differential equation. And we were all like, but it's true. This is the thing. So the brachytherapy sources themselves. So two main options for brachytherapy sources. We have iridium 192 and we have cobalt 60. They are roughly the same size. If you see here, it's 1/10 of a millimeter difference. The miniaturized cobalt 60 is the same grain of rice. There are slight differences in terms of the energy and in terms of the specific activity. Because this has a significantly larger half-life, it's not releasing, even though that the energy is higher, it's not releasing at the same rate. So your treatment times with cobalt 60 are going to be different. And they're going to be increasingly different as you get closer to the half-life. So this is something to consider in when you're thinking about throughput. You can treat the iridium patients roughly in the same amount of time, not same amount of treatment time, but the same blocks of time, even though the source is decaying, but you're switching them quicker. The cobalt-60, the time becomes significant that it may take up another treatment slot in terms of your throughput at the end of life for the source is going to be different than your throughput at the start of life for the source. And that comes into play when you're making your justifications. So about 1% a day for iridium 192. And we do those source exchanges every 3 to 4 months. I've seen both. I've seen some do it 3 times a year. I've seen some do it 4 times a year. And then this cobalt-60 every 5 to 6 years. Again, once you get to year 6, it's getting a little tough on timing. So I mentioned this before. I kind of touched on specific activity. So it's kind of how much radioactivity, how much energy is being released per unit volume. So with a higher specific activity, you can make a source smaller. So the iridium 192 has a higher specific activity than cobalt-60. So for the sources of the same size, which is what you have here, you're going to have a lower activity. The cobalt-60 source, you're not going to have a 10 Curie source. You're going to have closer to a 2 Curie source. And what that means is it's not releasing as many photons or as much radiation as the iridium 192. So the iridium 192 it's able to pack a bigger punch. I mentioned also we're talking about activity. We've been talking about activity. Activity is actually a really difficult quantity to measure. It's very dependent upon geometry of your detector, and there are other elements. But what we can measure really well is air kerma. And air kerma is measured with an ionization chamber, and we use that to correlate with an expected activity. It's a subtlety, but this just goes to the importance of knowing what you're getting. We talked about your afterloader and knowing your afterloader. When you get your source certificate, know what units that they're using. And it'd be nice if there was just one way to define a source, but there are several ways. So know what units are on your source certificate. It's very important. So iridium 192 has an activity about 5 times higher than cobalt-60. And this is what I said, the 10 versus the 2 Curie source. But the air kerma rate is actually lower. So the dose rate is about 1.8 times higher for iridium than cobalt. These are some subtleties. So you're actually you're going to get your treatments in about half the time with iridium versus cobalt. And then that separates even more as you get towards the end of the source line. Things to consider in terms of patient throughput and how many patients you could treat a day, which really goes into your justification for starting one of these programs. So another question, the last question, I believe. Which property most influences how small a radioactive source can be fabricated for HDR treatment?
So before the war, we had source delivered to Ukraine by plane, and nowadays planes are not fly to Ukraine. So in the beginning of war, we did have a chain disruption of sources delivered to Ukraine, but now we have sources delivered by land, and it's back again on track.
And are those mostly from Eckhart Ziegler, or is that your, or are they from all over?
No, no, actually, we have just a couple of Electas and Varian, as people replied. So those are from Netherlands and from Switzerland, I think. I believe
Okay.
Varian from Switzerland.
So looks like we have. So I'm not sure how to. I'm not sure how to take this response. I'm gonna think about this one. So we have This is the most diverse set of answers we got, and I'm gonna put it on me. That's my responsibility to convey the information. So the property that most influences the size of the source is the specific activity. That's how much punch you can pack into it. But I got a diverse range, and the half-life, I see that some of you said this, and that is related to the specific activity. I understand that, and that may have muddied the water. The photon energy, I also see where this logic comes from. The encapsulation material, not so much. But this is what I was looking for, and I'll aim for more clarity in the future. So let's wrap it all up. So we talked about some of the units. We talked about even in the beginning, we talked about who Becquerel was. And he was kind of like that uranium glass. He's like, why does it glow? And this is the current unit of activity. It's also people use Curie, and I think when I started my career, we were still using Curie very commonly, and more it's now just disintegrations per second. So Becquerel, they're both important. These are both valid measurements. But in brachytherapy, and I mentioned this before, activity isn't something you can necessarily physically measure. You can't. It's something that we can measure surrogates for. So even though activity may be how we define the source strength, it's not really what we're measuring. The source strength is actually up here. I don't. The red circle came down, but you can see this reference air Kerma rate. This is what we use to define the source strength, and then we correlate that to, and that's why it says estimated source activity. So we measure the air Kerma rate, and then we estimate the activity based off of that value. So it's really important when you get one of these certificates that you're very clear on what you're entering into your planning system, and you're clear about the units. So this is also something that sometimes a mistake is made. So some people, there are two different schools of thought. Some people measure they measure the air Kerma rate themselves with their well chamber, and then they put that value in. Others measure it and make sure that it matches the source certificate, and then they put in the source certificate. That's the method that I do. What I'm trying to do is not make a mistake. I don't have absolute confidence that I'm always going to measure it right, but I know that if they match, I can be pretty confident that this certificate is good. So that's my recommendation. I know that there are other schools of thought. That certificate again shows an apparent activity. It's estimated, and that may be what your planning system wants you to put in there. Just understand how this is correlated to, or I'm not sure if you can see my cursor, but how air Kerma rate is correlated to the estimated activity. And just a brief discussion. I don't want to go into too much about this, but what is air Kerma? You're capturing the photons that have been released in air. So the kinetic energy, and we know that the photons carry kinetic energy. That's they're moving, their electromagnetic waves moving in space. Released per unit mass. So you have a unit mass of air, and you capture all the ions that are produced. So your first interaction from a photon creates those secondary electrons, which then have that kinetic energy, and then those are collected. There is some losses through collisional kerma and radiative kerma in terms of bremsstrahlung, but those are minuscule for the energies that we're working with. The idea is that you can't determine how many radioactive atoms are in your source, but you can determine how much energy it is putting off. And everything that we see or everything that we measure is kind of a shadow of something that we can't see or we can't measure. This is the shadow for activity. This is how we measure activity. So in practice, there are different ways to express it. Again, I wish there was just one way. I wish it'd be nice if we all spoke the same language, but maybe it wouldn't. Maybe there's beauty in having multiple languages and multiple ways to say things, and it's more of a limitation that I haven't learned another language. But there are different ways to express air kerma. So in some cases, and this is different between the States and Europe. In the States, they express it as air kerma strength, and this has this D is not it's in centimeters or meters. It's not consistent. It's not one or it's not just one of those. Whereas in Europe, they're much more standardized, and they're very clear that it's just expressed in meter. The reason that I'm just pointing this out is because air kerma, again, it's this unit. It can be interpreted differently. Someone can use different units, and you're going to get a different value. So it's just something to be very sensitive to. So again, whenever you're getting your source certificate, read it carefully. And it's going to depend on the source manufacturer, and again, it goes to the company you're using. And I said that we had the last question, but we didn't. We have one more. So I think there are 5 questions. So why is air kerma strength preferred over activity for clinical source specification? And I've thought about the order to put this. If you put the physics first, it kind of a lot of the clinicians just don't love it and they go to sleep.
I like your order. I like your order.
So, but it's at the end, so we're gonna make sure everyone's still awake.
Good job.
I'm liking what I'm seeing. This is
It is a reflection of the lecture, so.
I'll take it. I like it.
We also have a question in the chat. So remaining daughter of nuclei are also radioactive in some cases. Does it common to consider this radioactivity as a dose formation factor?
I wish I could read that. So say that. Repeat that. So.
Yes. So radioactive daughter nuclei is also radioactive in some cases. So the results of decay. So is it common to consider that radioactive dose as formation dose factor?
So in many sources, so cobalt's kind of clean. It's got those 2 photons. Iridium is messy. It's got like a big spectrum, and that is all included in the dose. We're not just looking at the first or the primary decay product. We're looking at the full spectrum of energy that's released. So it's, and it looks like we've got over 80, and about 80%, which is reasonable, Pareto, got this correct. So air Kerma strength accounts for the geometry and the photon energy in a measurable quantity. So the activity, again, we can't measure how many radioactive atoms are in a material, but we can measure the energy released from that. So that is, and most of you again got that correct.
Yes.
So a brief discussion on the interactions, and I think this is good because it's maybe not so much related to the daughter question, but still how we account for the dose. We're not just accounting for the dose from the primary, just that's coming off of the source and interacting with the tissue. There are other things that lead to what's deposited. So there are four principal factors. So there's the distance. This is a big one, the inverse square law. There's self-attenuation within the source itself, like the encapsulation. You have it's the radioactive source is in a steel encasement, and that's actually gonna be like a filter for some of the really low energy stuff. Then there's the attenuation from the surrounding medium, and also what's really important to also consider is buildup. So buildup is really important in shielding as well, but in this case, buildup is going to lead to a really elegant element of brachytherapy. So the inverse square, and that's that the inverse square is by far the biggest contributor to dose drop off around the source. So what ends up happening is that the dose drop off due to geometry is accounted for, or the dose that's attenuated is accounted for by the scatter back in, the buildup. And so what you have is geometry, the distance from the source being the primary factor in dose delivery. So distance is everything, which is also, it's a good thing and it's a bad thing. This means that if you get the source in the wrong place, again, sensitive to operation or the operator, sensitive to the clinical placement of the applicator of the source. If you get it in the right place, it's going to deliver most of it there. And then as you get further away from it, less and less, it drops off dramatically, and it follows very much the inverse square. So within a few centimeters, very little dose. It's a beautiful and elegant aspect of brachytherapy. So some of the things about and that holds true, that holds true for both sources, but some of the things that are different between cobalt and iridium is this radial dose function. That's due to the source encapsulation. So what you have with iridium is kind of a butterfly. You have where it pinches in because it's self-attenuating along the wire, and it pinches in more at the bottom. So it ends up kind of maybe a butterfly might be an approach, or maybe more of maybe kind of like an apple. It pinches in. With cobalt 60, with having a higher energy, it doesn't have that effect. The wire still pinches it in a little bit at the bottom, but not at the top. It's more of a spherical dose. So you're gonna get a slightly different dose distribution with cobalt 60. Although that inverse square element is still gonna hold. So there's just a little bit of difference between the two, and there have been studies that show a treatment plan with one versus the other, and they're very similar. So the concern about the different energy, that shouldn't necessarily go into your planning of what source to get, but more about the source exchange. And then I did mention that throughput that's going to change over time. So we are very close to the end now. I'm just going to kind of review what we talked about. So you say, tell them what you're going to tell them, or it's tell them what you're going to tell them, tell them what you told them. So this is me telling you what I told you, or what I shared with you. So we overviewed the treatment process, the patient selection, like who's good for it, the outcomes, you know, the good, the bad, the ugly, the infrastructure requirements, like, and I can't stress staffing enough, and staff training, and the skill of the operator, the skill of the clinician, the room requirements. You have options for the equipment that you use, and you have options for the imaging that you use. All these should be well identified so that you can make a case to your administration, whether that administration is the federal government or a local private hospital. Either way, you're going to need to show that return on investment, and that's going to be based on the amount of patients you can serve. Then we also reviewed the basic physics of HDR sources, and I know you're going to go into greater detail in further presentations, and I hope that this just serves as a primer, so that these things are fresh in your mind when you're reintroduced to them. So we did talk about kind of how they're produced in terms of activation, the way that they're encapsulated, their dimensions. They're all about the grain of the grain of rice, the decay, and we did mention how that interplays with specific activity, with cobalt having a lower specific activity than iridium. And then we talked about the unit of source strength. And if that is a little vague, or it wasn't entirely clear, I think that should serve kind of maybe as a reminder that when you do get your source certificate, make sure that you are clear on the units that you are using. So it's kind of a cautionary piece. And as far as references, this is all derived from the AAPM, which is and ABS and the IEAE. I should have put the ABS in there because obviously they're big players and they're a big part of this. And these are links to reports. But I'm giving a plug for the AAPM. It's not too much. It's based on Ukraine is a World Bank B, so the fees are 15% of the US. But then you get, and this is the value add, you get access to the NCRP and the ICRP, and all the reports are free anyway. But consider, and then also you can join committees, and you can see Natalia, and we can all continue to rise the tide, lift all the ships. So with that, I want to thank you for your time and attention. And if ever I can be of assistance, please reach out, and do remember that you have a friend in Ohio.
Thank you very much for great lecture.
Oh, it was amazing lecture. That great work. It was quite impressive, and I like how you compared cobalt and iridium, and that's a very, very good question to answer actually for Ukrainians at the moment. So I know that Arjit needs to leave. So thank you so much, Arjit, for moderation, and we'd like to open the floor for questions and discussions. Any questions from the audience? You can either type it in the chat, or you can turn on your mic and ask a question. Don't be shy. So I see Elizaveta.
Hello.
Yes, hi.
Can you share maybe some guidance or whatever where I can find more information about the data, about the camera and activity measurements? So you already told few points how it's going on, but how we do this assessment, how we transfer from one unit to the effective dose and whatever. Some more details about the dose assessment, please.
Yeah, I can do that. And I think TG34 talks about measuring source activity or measuring the air karma. I can, and hello, I can share some other sources that can maybe Natalia could send out afterwards that can help with that. And what I might be able to do, this is something that is share an Excel sheet. I don't encourage you to use it, but I encourage you to examine it if that would be helpful.
Sounds good. And we'll have a little bit more information on that also in the next lecture. So there would be a little bit of repeat and more details on how to do the measurement. And I will share whatever Peter shares with me. So I'll share with everyone. Thank you. Any more questions? So I see great comments, really nice lecture. Thank you so much from Olena Pavlenko. From RJ, thanks, Peter. That was amazing. Thank you, everyone, for attending.
I also have a question, Peter. You showed an example of iridium assessment of brachytherapy. And if you can confirm that or comment on that, that if you buy actually cobalt, that the price of cobalt is much more higher and you can actually sign up for a contract of having multiple iridiums. So that would be the main, probably the main challenge is logistic rather than cost of one source or having one source for many years.
Well, yeah, and I can comment on that, that as you do get, there are advantages in terms of source exchange. You don't have to do them as frequently, and so that gets rid of those logistical concerns. However, the cost is still roughly the same. They charge more for the cobalt source. So at the end of the day, you end up paying a similar price for cobalt or iridium, but you have to manage those source exchanges more frequently for the iridium. So there are savings to be had in terms of the human resources that you have to devote towards frequent source exchanges. But the cost of the source, again, the cobalt costs more than the iridium.
I was wondering, Peter, about the Accurus. Do you have any stats? How many departments, let's say, around the world or maybe in the US are actually using Accurus for their dose calculation? Or it's still mostly water-based?
It is mostly water-based. I don't have any stats on that. I have personal experience. I know that there's been a slow adoption.
Right.
And I'm not sure what the resistance is. I mean, the common resistance to change is change itself, but there's also concerns about how the clinical data, the historical data that we use to make our decisions, was collected, and then is that transferable? Because if you're gonna switch to Acuros, you're going to have different dwell times, and that they may be significantly different in some cases.
Right. Yeah. But the external beam went through this, right? For example, was adjusting prescriptions to lung treatments. And so we've done this. So we have to do this at some point, I think.
I agree. At this, I also, I'm flipping it. It's external beam is, let's be honest, it's fuzzy. All radiation is a little fuzzy. There's some safety margins there. Here it's very, the safety margins are narrow. So I feel like we have to be maybe even more conservative. This is my take. But I think if we collect data and we do it in an evidence-based fashion, we should move forward.
Right.
and start with the safe cases.
Yeah, that's great answer. Thank you so much, Peter. Thank you for a great lecture. I was wondering if people would turn on their cameras. We'll take a photo with Peter and send him to put it on his wall, maybe.
I have pictures over here. So that's a wave guide. That's a high energy wave guide.
Oh, yeah, that's a copper.
Yes. So that one's like 18, and this one up here is a 6. So
Awesome.
friends with your
Is it from
engineers.
decommissioned machines?
Yeah.
Okay, awesome.
Less than 10 MV energies.
Yeah. Yeah. They're fun. They're fun.
If you can turn on your cameras, please, we'll take a photo. I know it's late in Ukraine, but it would be a great photo. Oh, nice to see you, everyone. Oh, great. Look how nice, Peter. Yeah, so a little bit more turning on their cameras. Excellent.
But I want to thank everyone for staying up late, and I hope you all get good rest. But thank you, and
Smile, everyone.
yes.
Yeah, that's great. Thank you. Thank you so much, Peter. It was excellent lecture. Amazing. Thank you. You're a great educator.
Thank you, Natalia. Bye, everyone. Have a
Bye,
wonderful day.
everyone. Bye-bye.